Hello, and welcome to the AMA's Steps Forward podcast series. We'll hear from healthcare leaders nationwide about real-world solutions to the challenges that practices are confronting today. Solutions that help put the joy back into medicine. AMA's Steps Forward program is open access and free to all at stepsforward.org.
Hello, everyone. Welcome. My name is Dr. Chen, Physician Director of Practice Sustainability here at the AMA. On today's podcast episode, I'm joined by Dr. Stephen Grubbs, VP of the American Society of Clinical Oncology's Clinical Affairs Department. Welcome, Dr. Grubbs. I'm looking forward to our conversation today.
Great. I'm happy to be here and happy to share some insights from the American Society of Clinical Oncology on this important topic.
Awesome. Well, I know the American Society of Clinical Oncology, and we'll call it ASCO at this point, recently joined the AMA's Behavioral Health Integration Collaborative, a group dedicated to catalyzing effective and sustainable integration of behavioral and mental health care into physician practices. Dr. Grubbs, before we dive in, could you share a little bit more about yourself and your background with our listeners?
Yes, thank you. So I'm a medical oncologist that actually started in practice, maybe I'm ancient now, in 1984, and have always been an AMA and ASCO member. I built a practice in Wilmington, Delaware from scratch in medical oncology, outpatient oncology, and was fortunate enough along the way to run the National Cancer Institute Clinical Trials Program in Delaware for 15 years, as well as, certainly being an active member. I was actually an AMA delegate for a while and also through the ASCO volunteer systems. And one of the things I've enjoyed over the years is working in our state at the state level on a cancer control program for really over 20 years. It's been quite successful in reducing mortality rates of cancer in the state of Delaware, as well as eliminating some disparities in healthcare. So it's been a really fun career, and I'm in my 9th year now at the American Society of Clinical Oncology, and was brought there to begin a new department that would begin to develop programs for our practicing oncologists, and along the way acquired our quality programs. So you'll hear a little bit about those today because they certainly play into this topic that we're going to talk about.
That's great. Being a radiation oncologist myself, I think that the oncology community as a whole, and ASCO specifically, has taken some very important first steps in behavioral health integration. I think one of which is the wide adoption of psychosocial distress screening as standard of care. I used it widely in my practice and adopted it as my standard of care. But what challenges have you seen with the implementation of this distress screening, and how did ASCO and other leaders pave the way for this to become reality?
Yeah, it's a really good question. I think you've brought up a very good term here, and it's one of the ones that I've been working so hard on with our members at ASCO, and the word is implementation. We have lots of publications and resources, but how do you actually implement these ideas and actually make them functional in your practice with your patients? And I think that's where we've really been pivoting at ASCO over the last several years, is really begin to look at how we can help our members implement not only the behavioral health issues, but other issues that are complex now in practice, taking care of complex patients. One of the things that ASCO did, and this really was starting around 2020, and I'm going to say this, we really pivoted, like a lot of folks, looking at health equity issues. And behavioral health and health equity issues really are common with each other. Health inequities actually create even more behavioral difficulties than we just get by having a diagnosis of cancer. And we did a survey on our members, and I think over 70% of them said that they were aware of social determinants of health and how that was impacting their patients. But only a third of them said they really felt comfortable trying to change anything about it. So as we've developed our programs, we'll talk about them a little bit, we've kind of put those two together, looking at social determinants of health and matching it with behavioral health questionnaires and ideas, because one leads to the other. So they're not inseparable. So I think that's been one thing we've tried to do with our practices moving forward, is really looking at that. Now, I mentioned earlier, I kind of took over ASCO's quality programs about 7-8 years ago, and we've actually made a transition we are transitioning right now from ASCO's bedrock quality programs called the Quality Oncology Practice Initiative, or COPI, that a lot of people know about. And that was a program that's run really well for the last 20 years and really was based on doing what I would call measures for care delivery processes. they really looked as one-offs. Did you do the right test for the right cancer? Did you give the right drug for the right cancer? And we've actually turned that around now and have developed a new quality program transitioning from COPI to really looking at the entire care delivery for a patient and their family. And we're really looking at care delivery now rather than these one-off process measures. So we've actually started we worked with the Community Oncology Alliance, COA, to put together an idea of what should a really well-designed, patient-centered care delivery system look like. And from that, we borrowed the ideas from the primary care physicians in their patient-centered medical homes and have developed an oncology medical home set of standards that then we have now turned we did a pilot for 2 years, but opened up to the rest of our membership in the last 9 months, a certification for this patient-centered medical home. Now, a key component of that is really looking at behavioral health and not just looking at it and asking the questions about it, but actually doing something when you find there's a problem. And that hooks all together with those social determinants of health. One of the things that makes our certification program interesting is every 3 years we do on-site surveys of the practices we actually certify. And they have to demonstrate not only are they using these tools to measure the behavioral issues for their patients and families, but they're actually doing something with it. And one of the key parts of this certification is patient and family navigation. So one leads to the other. You got to measure first, and then you have to act, and that's where the navigation comes into the entire system. And we're actually beginning to see some really nice results with the practices we've certified before. And I'm going to say this, even though we believe that we are adopting this, there's a lot of practices that haven't adopted this to certain ways. And I think what we found and what comes out of this is establishing standard operating procedures in a practice of basically how to look at behavioral health and then do something with it. And more importantly, change the workflow in a way that you now have this incorporated into your practice. Now, we're not specific on how a practice does it. We let each practice decide what tool would they like to use, show us your procedures of then what you do with it, how you interact with your community to help get services. And again, that's what we're looking for is practices are doing this, not specifically telling them how to do it.
I think that's really important that you mention sort of a framework for working. I think one of the biggest things that I had in my practice was we didn't know where to start. And so this framework that you've developed with ASCO and other partners, I think has really shown the way and really allowed folks that don't really know where to start to say, hey, this is the way we can do it, especially moving now towards patient-centered care and not just healthcare being, physical healthcare, but also behavioral and mental health. So I think that that's a very key and important issue to highlight.
Well, one of the things that I learned from our pilot, we had 12 practices, and this works for all kinds of practice. We had academic centers, large hospital public systems, and independent practices from 4 oncologists up over 100. What I found was that group, and it's expanding now, became a learning collaborative. Met monthly. There were things that we showed them and taught them, but the most important thing is they shared best practices. And as one group would discover something that worked well in behavioral health or social determinants of health, the other would learn from it and pick up on that. And I tell you that, I have to admit, I did not appreciate what a powerful tool that is, and the feedback that the practices have given us of how important it is to have those discussions with each other, I think is really, really important.
I think that there's a lot of success here that we can talk about, but I also want to talk about some of the pitfalls and challenges, because I think a lot of folks, they want to know that they're not alone in all of these challenges that they're facing. And how have ASCO members sort of gotten over these hurdles and these challenges that they've had in adopting behavioral health integration?
Well, I would start with the first thing. If you don't measure, you don't know where you need to work and where you have to do practice improvement. So I would say that gets back to that whole topic we started with, was how do you implement a good, initiative here to take care of behavioral health? And that really comes to some of the things I just talked about, is developing your practices, standard operating procedures, and then working it into the workflow of the everyday care of patients. And that really gets back to the concept that we've built our certification program on team-based care. So the whole team has to be engaged and has to be part of this whole process. and buy into it and see the results of it. So that's the first step in this whole thing, is getting the team engaged and understand that this is an important thing. Now, there are different technical ways practices do it. We've certainly seen that. I will say the tool that I've found the practices have found most successful in behavioral health is the NCCN a distress screening thermometer, that's the National Comprehensive Cancer Network. And it's actually a distress screening tool that puts social determinants of health together with behavioral health issues. And like I said, they come together. So I've seen our practices, we have a lot of different resources out there they can use, but that's been one of the most popular ones. And then the second part of that is actually integrating that into the electronic health record. So the data is right there to look at, and then setting, numbers on scores there to say, this is clearly where intervention has to occur. And of course, the standard operating procedure for cancer patients is, when should you be doing this? If you do this every time a person comes into your office, they're going to get worn out from it. So there are sentinel events that we try to identify, or the practices do, where these distress thermometers should be deployed and looked at. For instance, a new diagnosis of cancer. The first time a patient comes here, you can only imagine the anxiety and issues that come out of that. But before you start a chemotherapy treatment regime, you should go that again. If there is a change in the cancer, particularly for the worse, you need to have that test again. Survivorship time, periodically pop in and see how we're doing on that. So those are the types of standard operating procedures we're watching the practices build to know exactly when to deploy the tool, and then take the next step to put it into the navigation system to deal with the resources that are going to be required to help patients through that. But that gets to the other barrier out there. Again, there's a lot of times where referral areas to be able to help these are not adequate, or the time you have to wait. So that's a real challenge I think we all have, is having the resources to deal with some of these behavioral health issues that are beyond that of the primary oncologist and their team. And that, I know institutions have resources, independent practices have to connect with the community. That's one of the requirements of our certification. But even then, there's a lack of resource. And that really gets around to the whole problem we have in behavioral health in the United States, where it just is not funded well for the services we need to give people. So again, we're not going to solve that one, but at least make the effort to find out what are the issues for an individual patient and their family, and doing the best you can find in your community to connect them to the resources to help them through that.
Well, I know that you've just sort of outlined that one thing that is absolutely necessary is to grow coverage for behavioral health. What other hopes that you and or ASCO have for putting together other plans and initiatives in sort of furthering behavioral health integration, as time goes on?
Well, one of the strengths of ASCO is we have a really wonderful guidelines department, all our volunteers. And I know that we put out guidelines, I think it was in 2014, for looking at anxiety and depression management for cancer patients. And that was just actually updated last July. So again, we always like to build our programs and the standard operating procedures from evidence-based medicine. So those guidelines are very helpful, and they will continue to be updated. And again, I would say one of the things we hope to see more of over time is ongoing research into how interventions in behavioral health really do change outcomes for our patients that have cancer and other diseases out there. So I think that's a thing we look forward to. Now, it's interesting, there's a special category I will mention in cancer, and those are our patients with advanced cancer. They are living longer than ever. The interventions we've had in the last 10 years have taken advanced disease that used to have people die in months, and now they're living years and years. So this is actually a special area where we really need to look at intervention, because there certainly are behavioral health issues. Living with a disease you're not going to be cured of. So ASCO actually worked with a group called the Multinational Association of Care in Cancer. It's called MASCC, and just published last month standards for dealing with the behavioral issues that come up with advanced cancer patients. So again, those are the types of things, from my perspective, actually trying to implement that. Those are the things we want to see coming out of ASCO and other professional organizations that we can then begin to tweak and implement in our standards for our outpatient care of cancer patients and their families. One other way that we help practices is ASCO has a robust quality training program where teams from all types of practices, 3 or 4 people come in and they really learn how to do quality improvement over a 6-month course with hands-on teachers. It also, they have to pick a topic to work on. And I know at least 3 of our teams recently have actually used that system to work on actually implementing and increasing the number of patients that actually get screened for anxiety and depression. So again, that's another tool we have to help practices learn how to change their workflow and actually then measure the results that they're finally getting there. And like I said, first step always, you got to measure. If you're not measuring, you can't do anything about it.
Switching gears a little bit, what does ASCO as an organization hope to gain from joining the Behavioral Health Integration Collaborative?
Well, I mentioned what I've learned is, the collaborative we set up among our practices, we've all learned from each other. So I think that's the first step here, is by collaborating with other professional societies that, we're going to learn. And hopefully maybe they can learn some of the things that we found to be beneficial. So I think that's the main thing, is what are we going to get out of working with each other and learning from each other? And I think that's really the main thing that I would see coming out of this collaborative together.
Any other practical tips or pearls of wisdom for healthcare leaders, especially those that are in non-primary care specialties who may want to start their journey towards behavioral health integration?
Well, sure. Those of us that are in specialty areas have patients that have, as I mentioned, complex disease. And this has to be a part of dealing with complex diseases, your behavioral health and your well-being. We talk about well-being in the physician community, about well-being in our patient and family communities. So this is really an important subject. And I guess the advice I would give, folks out there is make sure that when you begin to think about working on this journey of improving behavioral health for your patients and families, check in with your professional societies. Because one of the things that I always scratch my head at, and I'm going to say it, I'm not sure we do the greatest job of letting our members know what resources we all have to help them. And I know we keep trying over and over again, but when I bring something up, somebody says, gee, I didn't know you had that. So, between your professional society and the AMA, you should make sure you're looking at what they have and asking them, I want to work on a subject here. Do you have resources that can help me do that? And then, of course, that moves to the next step is you really need to focus on implementation. It's one thing to get the resources, but you got to figure out how to implement. If you don't implement it, nothing ever happens. So that's my advice. Find the resources, ask your professional societies, and then really work hard at implementation.
I think that's a great ending thought. So with that, I thank you so much for joining us today, Dr. Grubbs. Listeners can find out more information about the Behavioral Health Integration Collaborative and the other resources mentioned in today's episode in the episode description.
Thank you for listening to this episode from the AMA's Steps Forward podcast series. AMA's Steps Forward program is open access and free to all at stepsforward.org. Steps Forward can help put the joy back into medicine by offering real-world solutions to the challenges that your practice is confronting today. We look forward to you joining us next time on the AMA's Steps Forward podcast series. stepsforward.org.